Alright, so part 2 of our lecture on the overview of lungs. So last time I got finished up, ran out of time, we were talking about the pleural space. So the pleural space is the space between the wall of the thorax and the lining of the lungs. So we said we had a little bit of space in there, and in that space is fluid. So fluid, it's mainly going to be just protein and fluid in there. It's not going to be any blood or anything like that. That's going to kind of serve as a buffer and a lubricant for our lungs to move around within our thoracic wall. And there's not actually that much fluid in between our lungs and our thorax. So it's actually only going to be about 10 millimeters per lung surrounding our actual one of our entire lungs. So 10 millimeters, going back to my syringe, is that much. It's just that much. Not much at all. And it's under very tight regulation. So under normal circumstances where we only have 10 milliliters, but we can run into a lot of pathologies, which we'll go into here, that can increase the amount of fluid, or pleural fluid they call it, in that space. And that's a big problem sometimes. So in our pleural space, we have our parietal pleura and our visceral pleura. So our visceral pleura, we can remember visceral means like organs or vital organs. That's going to be lining the surface of our lung. Okay? And then our parietal pleura is going to be against our thorax. So it's going to be the outermost or superficial lining of the thorax cavity. Okay, so in our two respective linings, we have the parietal, and this is going to be full of parietal capillaries, they call it. So parietal capillaries are the main source of our fluid that gets pushed into the parietal space. And then we also are going to have these things called stomata in here, which are just openings into the parietal space from the parietal lining of the thorax. And these are actually extensions of lymphatic channels. And lymphatic channels, we all know, are just carry lymph to our lymph nodes and eventually back to circulation in our body, and that is more of a clear fluid. So it makes sense that the fluid in here is going to be a clear protein-rich fluid, and it's under very tight control, like I said. On our opposite side, on our visceral side, we've got the lungs, and we've got a further space in between that lining, or the cells of the visceral pleura, and our visceral capillaries and our visceral lymph channels. So this side is not going to contribute as much to our fluid composition of this space under normal circumstances. In fact, it's really not going to contribute that much at all under normal circumstances. If everything's right and you're healthy, it won't. Okay, so the way we control the amount of fluid in here, like I said, it's only about 10 milliliters, is we're constantly allowing fluid to either drain or be forced out of the capillaries into the space. So it's going to drain out of the stomata into the lymph channels and back to circulation, or it's going to be pushed out or filtered through the capillaries into the space on the parietal side. And the way we push fluid or absorb fluid is through a couple of different mechanisms. So we've got our two mechanisms to maintain our fluid volume. So we've got our hydrostatic pressure and our colloid onotic pressure. So hydrostatic pressure is just it's your blood pressure. It's the actual pressure that the liquid part of your blood is under, and as we know that it can be vary from 120 to 90 depending on what part of the cardiac cycle we're in, or 120 to 80 if we're healthy, and what part of the cardiac cycle we're in. But that force of the fluid pushing against the vessel walls is going to force out some of the fluid of our blood. It's going to force out some of the plasma and some of the proteins. Okay? And our epithelium lining our capillary cells, we remember in histology they look like fried eggs. They have small spaces in between them under normal circumstances that can actually allow some of the water or plasma to be pushed through and some of the proteins as well. And we also have another mechanism that's regulating this in our colloid-onotic pressure. So this is the pressure of, you can think of this as the diffusion gradient, just like osmosis. We have proteins in our blood, and the main one's going to be albumin. We know that from our previous lectures. And those are going to exert a certain force on the pleural fluid from the parietal capillaries. And if we have a lot of albumin or other proteins within the blood, it is going to draw, if we have more proteins in here than are in the parietal fluid, it is going to draw a lot of our fluid back into the capillaries. And vice versa, if we have less protein in here and more in the pleural fluid, it is going to force a lot more water out, or a lot more fluid out. Okay, so those are two important mechanisms maintaining the fluid volume. Now, like I said, when the fluid is done, most of it is going to be channeled back into the lymphatic system for reuse in our body. So, we've got those two important mechanisms. Now, there's the pathology associated with this. Oh boy, right? So, our pleural effusion, which this is a high yield term to know and to be able to identify, because I did my time in the ER, and I don't know how many chest x-rays I looked at with pleural effusions on them. It was just so numerous. I mean, it was so common. It's so common and such a common pathology, especially in geriatric patients. But a pleural effusion is just going to be an excess accumulation of fluid in the parietal space or the pleural space surrounding the lungs. And most of the time it's going to manifest itself in a certain portion of the thoracic cavity, namely around the diaphragm and the lower lateral angle of the lungs. So it's going to increase and have a lot of fluid build up in that region, and that's going to put pressure on the lungs and allow you to not breathe as well. So our symptoms are going to be shortness of breath, chest pain, stuff like that, and it's going to be fairly obvious that we're dealing with some kind of lung issue from that, okay? And that can be due to the buildup of the fluid, can be due to so many different reasons, but they build off of our two mechanisms of hydrostatic and colloid-onotic pressure, excuse me. And if you're fairly interested, we've got one of the things, for instance, that I know can influence this is people with hypertension, and especially pulmonary hypertension. The hydrostatic pressure pushing against their vessels and pushing fluid out of their vessels is so great in their parietal capillaries that too much fluid is going to be pushed out into that space, and you're going to collapse a little bit of the lung because of that. It can also be due to an infectious organism, which is very common. And when you get an infection, you're going to have inflammation, right? So inflammation is going to go ahead and constrict our capillary epithelium, so there's more spaces in between it, and it's going to allow more fluid to cross into that space because of our hydrostatic pressure and our colloid-onotic pressure. So inflammation in the parietal or pleural membrane is bad, very bad. Okay, and with pleural effusions, we can also see a lot of fluid being pushed off through the visceral capillaries and the visceral lymphatics, because the pressures that are going to be associated with pathology are going to be able to overcome this space between the visceral mesothelium and the actual vessels themselves. Okay? So, easy enough. Another pathology we have associated with the lungs is cystic fibrosis. So cystic fibrosis is a failure of a certain ion channel in the epithelial tissue that transports chloride ion to the surface. On top of the surface of our epithelial cells, we have what's called our periciliary fluid. Periciliary fluid is just a fancy term for the fluid that's in between the cilia, okay, or on top of the cilia. And it's going to be up there, and it's going to function to, and chloride is too, is going to function to thin our mucus. So when we pump more chloride out, we're going to have water follow our concentration gradients. We're also going to have sodium dealt with in this, but he doesn't go into too much detail, so we don't need to worry about that. It's going to thin out our mucus of our different generations of the respiratory system. And thin mucus is good because thin mucus our cilia can beat up and actually work with in our musculoskeletal elevator and actually push through our esophagus and into the stomach. If you get it too thick, it cannot. So that's a very big reason why it would be bad. If we can't move the mucus, it just sits there, and it's a breeding ground for infectious agents, and it's also going to make it really hard to breathe because that mucus is going to build up over time. Alright, so the last pathology he's going to talk about in this lecture is a pneumothorax. So a pneumothorax can be caused by a lot of different things, but the one I want to go over is a traumatic pneumothorax from a penetrating injury. So if somebody for instance, stabs somebody, you get a knife stab, that's going to create an opening in the thoracic wall that's going to let air into this pleural space. And we know that this space is under negative pressure, so it's going to suck up a lot of air, or air is going to flow into it very readily. And air is not going to be able to flow out of it readily because of the nature of the penetrating injury. So when a knife comes into our skin, it's going to bow our layers of skin inwards towards our lungs. So if air were to push out against it, it would close our wound. So air can come in and can't come out. What's that going to do to the lungs? Well, it's going to build up in the pleural space, making that pressure positive, and put more pressure against the lungs, which can't handle that. They're very delicate tissue, and the lungs are going to collapse because of it, or at least one is. We can only do one at a time. If we had multiple penetrating injuries, we could get bilateral pneumothorax, but in this case, for the sake of it, we aren't. So a pneumothorax is just caused by air in the pleural space. And it's going to collapse your lung, and we obviously know why that's bad, right? It's because we can't inflate the lung anymore. So a subset of a pneumothorax is a tension pneumothorax. And a tension pneumothorax is when the lung is deflated so much and there's so much pressure pushing against the lung here that it's going to actually push against this lung and push against our trachea, and it's going to deviate from the midline, which normally our trachea is midline of us. It's going to push so much in there that it's going to impede on the respiration of the other lung. So that becomes a serious medical emergency, and that's why I wrote bad in big bright letters with 2 exclamation points. Last thing I wanted to touch on for this was lung volumes, and it's going to be the last thing in his lecture series on the overview part. So these are kind of hard to remember, so I'm trying to get some ways to remember them, and I'll share them with you guys. But the most important thing to remember with this stuff is the difference between a volume and a capacity. A volume is going to be a single specific measurement of air that comes into the lungs or out of the lungs. A capacity is going to be a combination of 2 or more volumes. So 2 or more of these measurements are going to give us capacity, and I'll show you why that makes sense here in a second. So our first important volume that we go over is our tidal volume. Tidal volume is easy to remember because just as the tide comes in and out and balances each other out, our tidal volume is our breath in and out. It's our actual, just normal breathing in and out. It's the volume that we normally breathe in and out. So it's between 3 and 4 liters, so it's actually going to only be a liter of air in an average adult. So that's an easier one to remember, okay? Now we come to the harder ones, which get a little bit more tricky to remember. We have the ability to change our thoracic wall with our intercostal muscles and our diaphragm and increase our volume of it. And according to Boyle's law, if we decrease the volume, we're going to increase pressure if we're dealing with a closed container. But if we increase volume, that's going to create a negative pressure effect on our lungs and going to fill them more. So the more we breathe in, the more our diaphragm pulls our lungs down, and the more our intercostal raises our thoracic wall out. We can breathe in more air than we normally would at rest. So with that, we have a couple of different volumes here. So the volume that expresses what more we can breathe in after we breathe in one breath. So this is my normal breath in, and then I can, if I try hard, I can breathe in even more. That's our inspiratory reserve volume. So that's the inspiratory reserve volume is just the measurement of the volume of air you can suck in after you took a normal breath. On the flip side of that, we've got our functional our expiratory reserve volume. So after I breathe out like normal, if I force myself to, I can really compress my thoracic cavity and breathe out even just a little bit more. So that's from here to here. From the end of a normal expiration to you not being able to push any more out of your lungs is going to be called your expiratory reserve volume. And you're normally not going to use that volume to perfuse your lungs. You're just not. All right. Now it's worth noting that we've got these couple different basic ones covered. The tidal volume, which is our normal breathing pattern, our inspiratory reserve volume, which is the amount more that we can breathe after we take a breath in, and our expiratory one, which is the amount we can let out even after we've let out what we normally would out of our lungs. We have a residual volume. So a residual volume is the amount of air left in our lungs after we took our maximum breath out. Because our lungs are always going to hold air no matter what. There's still going to be a little bit of volume left. And that is called the residual volume. You can't actually breathe that air out unless you crush your chest. Okay? So those are our specific volumes. So let's move to some capacities. Capacities are a combination of 2 or more volumes. So that's why this becomes beneficial to remember these 2 definitions. Our inspiratory capacity, or IC, is going to be the combination of our tidal volume and our inspiratory reserve volume. So the maximum amount we can breathe in. So it's going to describe the maximum total amount under any circumstances that you can breathe in. And on the flip side of that, we've got our functional residual volume. This is going to describe the maximum air that is left in our lungs after our normal breath out. Okay? And it's going to include our expiratory reserve volume and our residual volume. All right? So our vital capacity, which is kind of our last one we're going to talk about, that is our difference between the maximum amount we can breathe in and the maximum amount we can breathe out. It's very important. That's what we call it, the vital capacity. And then our last thing we got to remember is our total lung capacity. So this is our actual lung volume that we can